to have most of these sessions from last one. It's Mari and Moya have been helping me become a little bit more tech savvy, but I'm still learning. Hopefully, sometime next week I'll have last session and today's session up into a invite only YouTube channel. Okay, so this is one of the most important thing that I think that you know that can be a source of frustration, but it's really really important, and that is the first sentence here. Dental disease rarely results from a single entity. We grow up in an environment where because of the such a technology progress that we've had, we sort of expect A leads to B, B leads to C, C leads to D, and so forth. Okay. But as you know by now, human body doesn't really work that is singular synchronicity, so to speak. Okay. Um, and so what we have is a situation where it's a multifactorial. And I really want to drive home that issue, especially as we're talking about occlusion. And that is why it is so frustrating. There are so many multifactorial things, okay, that it has to be considered. And in my humble opinion, and this is one of the reasons why probably, and being able to detect it in real persons, in the patient, we probably don't have to worry about AI taking over this aspect of dentistry for a really, really long time. Okay. So I'm going to go back and start from there again. Dental disease rarely results from a single entity. It is almost always the result of a combination of factors. The same causative insult can produce a variety of response because of differences in host resistance. Okay? This is truly critically important. We're obviously talking about in context of occlusion, but it is truly important. The same, what you and I would call hyperocclusion, can have a variety of different host response. Okay? And we want to have the wisdom to sort of layer away that onion. Okay? So what you read about causative and contributing factors. Okay, if you expect high occlusion means mobility and that's the end of it, then you're gonna get confused because you're gonna see so many other issues coming out of high occlusion. If you think high occlusion equals TMJ, orofacial pain only, that is also going to throw you off because that is not the only manifestation of that. Okay? It is truly important that we drill that into our head. As obvious as it is, we often still think of A is equal to B, B is equal to C, C is equal to D in that sequence because it's easier for us to see it that way. But I can't emphasize enough of how human body never ceases to amaze me, particularly as I look at the occlusion aspects of it. Okay? And then the next sentence, the response can also be altered by variations in intensity or duration of the insult, sometimes to such an extent that a completely different set of symptoms may result from increased intensity of the same causative factor. One of the articles that I have shared with many of you in either in my other study clubs or when you were in the program with me was this article by Glenn Clark when he used to be at UCLA. Okay. And he talks about the relationship between hyperocclusion and TMJ symptoms. Okay, orofacial pain, and he talks about how and it's a actually a meta-analysis. It's a literature review article, um, but he talks about how he thinks that because the symptoms were short in duration, that it is okay. He comes to that conclusion. I know that's a gross oversimplification. Okay. But what if you have somebody who's had that same symptom for last 30 years? Or actually not symptoms, but let's say causes, contributing causes. Okay. You know, modern medicine, in my opinion, is slowly coming to appreciate long-term cause and effect in our society or our body. Okay. So, I know that I may seem like I'm deviating from occlusion, but I'm trying to, make sense out of all these things so that hopefully you'll have a chance to better explain to your patients as well. The way that I explain to my patients is this, basically. For example, you know, osteoporosis is something that we know that affects many, many people as we get older. Okay. And osteoporosis we know is basically softening of the bone, or shall we say, losing of the mineral content in the bone. But it's actually more than that. It's not just losing mineral content. Your bone is getting weaker, right? It becomes more brittle. Okay. And there, and in it, and as a dentist, we actually have to think about this much more so than many other physicians because of the medication that these patients are put on. And I'm sure you are tired of, people talking about osteonecrosis, right? All right. Now, most physicians only look at DEXA scan and use that as a basically end all evaluation of osteoporosis. But DEXA scan only measures the mineral content of the bone. It does not really measure the vitality of the bone. In fact, we know that when people go on them, put themselves on bisphosphonates, the bone may pick up more mineral content, so it looks more dense. Okay, okay. Um, you know, we have people basically who will have a lot of density in the bone, because of the mineral content, and they prevent, shall we say, a fracture, okay, because of the density, okay. But you and I know that if the bone was to get injured, they have hard time healing, and that's why they get, osteonecrosis, basically. That's why we say we don't want to be doing extractions on them. We don't want to be doing gum surgeries, osteosurgeries on them. We don't want to be putting implants surgeries on them, right? But so there are people who are thinking differently about the model of osteoporosis. And it's not just loss of bone density, okay? It's loss, it's where does it come from? It's not because of lack of intake, okay? It's because um, body is becoming more acidic over time. Why does the body become more, and what's that got to do with it? You may remember from biochemistry, if our body becomes acutely acidic, reasonably acutely acidic, our body has the ability to take mineral from our tissues, primarily minerals are deposited in bone, to try to buffer our body. Okay? Now, Why does our body become acidic? Because of the food, the type of food we eat. Okay. So we need to think of, I think I talked about that last time. We need to think of human disease process not as a still shot picture, not as a stop in time of today's condition. That is important too. But we need to really look at it as a movie of what led up to the current situation. Don't fall into the trap of these are today's pictures and this is how I'm going to make the diagnosis and make the future plan. I mean, certainly, as thorough as that might be, that is going to be helpful, obviously, but it oftentimes lacks the wisdom of understanding how it got to be today. And when you look at the history of things, you realize there is a lot of multiple factors that go into play there. So please keep that in mind because that's how I look at everything. Okay? Not just human nature, but frankly, about everything about human existence. Okay? We have to look at everything as a movie, as a moving picture of from the past, how it led up to be today. Okay, so I'm in the next paragraph. Because similar symptoms may result from different causes, and a variety of symptoms may result from the same causative factor, treating symptoms alone is generally short-sighted therapy. Okay, for example, hyperocclusion. There is a tooth that's mobile. Okay, because of mobility. And hopefully all of you recognize that's one of and the book indicates that that's one of the symptoms of bad occlusion. Okay, so we want to address that. But just addressing the mobility by grinding it away so that it doesn't contact may not resolve the whole thing because that's just a symptom. That is in itself is not the cause of the whole problem. Okay, it is always advantageous to determine the cause of both signs and symptoms. Okay, if the causative insult can be completely eliminated, such as occlusal overload on a painful loose tooth with a high restoration, the normal adaptive response of the body should activate a return to comfort and reduced hypermobility when when the overload on the tooth is eliminated. Okay, of course, it may still be necessary to repair damaged tissues, but this can then be done with a greater chance of long-term successful treatment outcome. Much of the confusion about cause and effect relationship results from failure to differentiate between causative factors and contributing factors. A contributing factor does not by itself cause disease. Rather, it lowers the resistance of the host to the causative factor or increases the intensity of the function or tension. Contributing factors may lower host resistance biochemically or increase intensity biomechanically. The resistance may be lowered in a specific tissue or in an entire system. Generally, the weakest links breaks down first. Okay, generally the weakest link breaks down. Okay, but I'm gonna say breaks down first because there are many different links. There are many different links. The weakest one breaks, but the others are stressed out too. In fact, you may have first two links that have broken down, and if you only identify one of the two links that are broken down, then you're not going to get all the result that you'd like to see. Okay? The greatest susceptibility to disease occurs when a causative factor is present in a host with increased stress and lowered resistance. Both causative and contributing factors must be considered when deciding on a path of treatment. Okay, and then but the most effective approach is to give the highest priority to direct causative factors. Okay, so I am resisting my tendency to just read the whole thing. So I'm gonna just skip over a little bit, okay? And I'm gonna go to the last paragraph on that section at the bottom. In a healthy patient with a perfect dentition, I skipped a couple few sentences. Note the variety of the responses that can occur if a single high restoration with deflective incline interference is placed on a second molar. So assume that you did a second molar filling or a crown that you did not notice that has a deflective incline interference. Where does that usually occur? That will usually occur on the lingual cusp, right? All right. So when that happens, it says, number one, the tooth may become sensitive or cold or hot. It may become achy. So this is something that a lot of people overlook. And that is when somebody complains to you about temperature sensitivity, okay? Oftentimes that can come from occlusion. It's not just because exposed root, because you look at the case and you see, oh, guess what? There is no gum recession. And yet the patient complains it is hot cold sensitive. And there is absolutely zero decay. There is absolutely oftentimes actually even zero restoration. It is not uncommon in my practice, once I have provided my patient, occlusal splint slash night guard slash what I call mandibular deprogramming stabilizer, MDS, okay? The patients will not only gain joint and orthopedic comfort, but then their sensitivities go away. Hot cold sensitivities will go away. Okay. And then they get comfortable and they get become complacent and they stop wearing it. And then 6 months later, the sensitivities come back. And the patient will completely have forgotten that association with the splint therapy night guard. And when they come in for the hygiene maintenance visit, they'll mention that to the hygienist, like, I'm getting cold sensitivity. And I go through the chart, I look at the patient, and it's not that clear, to be honest with you. Okay. And I go through the chart and I go, 3 years ago we had given you a splint night guard. Are you still using that? And they go, oh, you know, I got better with my earache. I got better with my muscle pain, so I stopped wearing it. Or I lost it. My dog chewed it up. Okay. And then, besides applying topical fluoride protection, I'll tell them, you know what? You need to start wearing that. However, if you have stopped wearing it for last year and a half, then you need to bring it in before you start wearing it because your jaw posture or teeth may have moved to the point where it may not fit as well as I would like them to fit. Okay? And that is really, hopefully, we're going to get to that point about the importance of follow-up adjustments by next time. Okay, so it is really, really important that this is something that I think most dental schools, the people who teach you occlusion don't really how should I put it, emphasize, right? Hold on one sec. So I want to really emphasize this. This could be considered a very early stage, early warning sign of occlusion that's beginning to go off. Okay. Number one. Number two, and just on the equal footing, the tooth may become tender to biting on it. They'll say, yeah, it feels a little sensitive. Like yesterday, I had a patient that I was delivering a crown. Okay. And he was saying, oh, I had so much pain with the temporary. I go, really? I go, yeah. I go, when did it start? After I saw you last time when I prepped it, because the tooth had a little crack. It had a vertical crack. So this is pertinent, right? You know. So then he goes, actually, first couple of days it wasn't bad, and then as the days went on, it became painful. I go, painful to what? He goes, like hot cold. So I go, okay, I appreciate that. Did you have to take pain pills? And he goes, no. And then I said, oh, so would you mind if I use different word to describe what you just told me? He goes, what's that? I go, what if, would you be offended if I use that word that you use pain as substitute that with, some people would say was severely sensitive. Okay, fine. Okay. But it went away quickly. It might have zinged you a little bit here and there. Okay. Is that truly what you and I want to call pain? Okay. Or was it tender? Things like that. What I'm trying to say is this. As dentists, we want to try to get our patients out of pain and get them comfortable. We want them to like us, right? How many times have we heard patients tell us, nothing personal, Dr. Lee, but I don't like coming here. I don't like to be in this chair, having you work on me, right? So it is human this instinct that we want to appease our patients, right? So that's our instinct. We want to jump at whenever they say pain, we want to reduce them having that pain, right? But if we use the word, oh, it's sensitive, oh, it's a little tender, right? Then the patient and I both tend to think like, okay, well, we don't have to have a knee-jerk reaction here. Maybe we have the luxury to think about this a little bit and sort it out. Okay? So it is important, especially when it comes to study of occlusion, how we communicate with our patients. And without offending them, because some people do get offended. Okay? I have to make sure, hopefully as you continue your study with me, you're going to learn to see that I try to be very particular, meticulous, and careful in my choice of words with my patients when I communicate with them. Because it is truly important that we communicate well without offending them. Because sometimes we unintentionally, right, inadvertently offend them because they somehow felt that we didn't hear that word pain from them, that they suffered, and I didn't give them enough credence to that, or that I seem to have ignored, right, their plea for help. So you want to be polite, okay? Those of you who are young, I sometimes have to tell you that patients who are more senior, they tend to be sometimes, they may not take your casual conversation style that well. If you're gonna call them by their name instead of calling them, "Hey Tom, how you doing?" Um, some patients may prefer to be called, "Hey Mr. Lee, how are you doing today?" There's a different tone that's coming through. Until you get a vibe from that patient, it's okay. We can bring down this wall a little lower. We can be a little bit more comfortable because the patients are more vulnerable. They are physically, emotionally, and psychologically vulnerable in a dental chair, especially if they're trying to hide their dental anxiety. Okay? So we want to make sure that when we try to elicit their report to us, and how they word it is important. Okay? Are they using the word sensitivity to hot cold? or is it pain? Is it tender to biting or is it pain upon biting? Okay. I think that's really important. And the words that they choose, and as you're trying to calibrate your verbiage, wording, okay, you can kind of get a glimpse into their psyche. Are they a crazy person? Are they bipolar? Okay, because some people, you touch them on their teeth and they jump, right? And then if they tell me like, oh yeah, it's tender, well, I have to kind of wonder about that. Anyway, okay, let's move on. The tooth may become loose, okay? The looseness, we will usually equate that to, let's say, um, 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 mobility in dentistry, okay? But I'm gonna say, do you have uh, how do you check mobility? Do you routinely check mobility on a second molar? What if I use the word fremitus to denote that looseness? How often do you check fremitus on a molar? Okay, so these are things that we have to think about our degree of sensitivity to what we're looking for in the mouth. Okay, the tooth may wear excessively. The mandible may deflect around the interference into other teeth that become loosened. And this is really a main thing that I try to emphasize that a lot of people miss. That you can have typically a bicuspid or a maxillary incisor become loose. They develop fremitus, and you can tell that they are having, occlusal trauma. Okay. But if you evaluate them only in maximal inner and CO, and you see that occlusal trauma on number 9, okay? But if you were to be able to deprogram them and get them into CR, centric relation, you will immediately recognize that they have an interference on number 15, like that photo, that picture figure A-1. I'm sorry, 1-1. It is entirely possible, and I've seen it many, many times myself, that a single contact on tooth number 15 like that will show up on your Accufilm will initiate mandibular deflection, try to avoid that. And then at the end of that deflection is where number 24 hits number 9. Because number 24 happens to be slightly more buccal, more anterior to compare to rest. And it is number 9 that's paying the price. And this stupid number 15 and number 18, they have no idea what's going on. They're not trying to hide it from you. It's just that they just don't feel it. Okay? In fact, the patient probably doesn't even feel number 9 being loose that much either. Okay? So it is truly important, that we when we are looking at occlusion, don't focus only on that tooth that's sensitive or mobile or even wearing away. You have to, by the time that you got to chapter 5, hopefully, Dawson repeatedly talks about the importance of understanding the TMJ, right? It is truly critical to see the whole system. TMJ is important, obviously, but the whole maxilla mandible, the muscles, you have to look at appreciate occlusion as the whole entity first before you look at the individual teeth. Even though the signs and the symptoms that we notice immediately or the patient notices immediately oftentimes are limited to the teeth. Okay, so number 6, other teeth can
Really?
be abraded as the mandible is deflected forward, just like what I just said. Okay, other other teeth can become sore as they are traumatized at the end of the slide, just like what I just said. Okay, forced deviation of the mandible can cause mascatory muscle to become painfully hyperactive or even become spastic. Okay, um, yes, Mylene.
Can you hear me okay?
Yes.
Hi, my name's Mylene. Hi, everyone. Um, so what is the causative factor
What is the causative
for
factor?
these
So,
symptoms? Like for
yeah,
number
so for
five.
example, that red dot on number 15, let's just say that could be the causative factor for having somebody who has, let's say, mobility of number 8. If the mobility of number 8 came from number, let's say, number 25, hitting it too much, singularly, okay, you can say number 25 is the cause of it, but no, not really. Number 25 is a contributing factor. The causative factor is number 15 and number 18. Okay, it's contributing. Number 25 was only contributing because it was sort of stuck to the same mandible, and yes, it is the one that's hitting number 8. Okay, but number 25 wouldn't be doing that if the mandible didn't deflect. Why is mandible deflecting? That's also a contributing factor. Deflection of the mandible is a contributing factor. But why is it deflecting? Because it wants to avoid hitting on that hyperocclusion on number 18 and 15 too much. So what is the causative factor? Just like going back, way back, I give this example to my residents for many years. I think it was like 98, 99, somewhere around there when I first started teaching at UCLA in AGD. I had a resident who was working on a patient for number 18 crown, single crown, number 18. Okay. And he had made a temporary crown. And it was Friday afternoon. Everybody is in a rush to finish up. He did early on in the residency, just graduated from dental school. Okay, he was running out of time. He admits that he probably should have spent a little bit more time on it. The patient goes home with a temporary that's over contoured and too big and high in occlusion. Okay, by the time next morning, patient's going crazy. I get a call from the resident. The patient is in all kinds of pain, toothache, da 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 da. Then it did have a deep decay. So initially, I thought maybe it was the pulp, acting up, endodontic flare up. So over the phone, the resident and I talked about prescribing the patient antibiotics. Okay, so the antibiotics uh, sort of patient does report that it helps by the time Sunday rolls around. And you might say, like, how does antibiotics work that fast? If I suspect somebody has a true endodontic flare up, I will give them whatever antibiotics I'm giving them at a loading dose. I do not start out amoxicillin, augmentin, clindamycin with one tablet at a time if they have a true flare up. Okay, so start out with amoxicillin. I'll give them 2 grams to start. Okay, And then for the first 24 hours, and this is the best part about amoxicillin if they're not allergic to it. Amoxicillin has a very high tolerance by the body, much more so than other antibiotics. Okay. So what I will normally do is start out with 2 grams, and I'll tell them for first 24 hours, you're gonna take the second and third dose as with 1 gram, not 500, 1 gram. So two. So I had tell them I prescribe them 500 milligram, and then I will have them do, 4 tablet initially, and then 8 hours later, 2 tablets, another 8 hours later, 2 tablets. You have to remember, amoxicillin is bactericidal, right? It actively kills the bacteria. It doesn't just prevent their proliferation like bacteriostatic, right? So if I do that within 24 hours to 36 hours, usually the infection or endodontic flare up will start to calm down. If they don't, within 36 to 48 hours, then I know that either I got a wrong antibiotics, if it's truly an infection, or it is not an infection. Okay. Normally I will switch over to cover anaerobe. Okay. Okay. Gram negative type of thing. So I will throw in either augmentin or metronidazole or something like that to that, right? If I go to augmentin, obviously I stop amoxicillin. But but so so now when I saw the patient Monday, going back to that particular patient, now she was a full blown. The initial tenderness of the tooth had calmed down, but now she's complaining of full blown orofacial pain. And when we look at history of her, she was already a documented, and the resident actually had written down, based on patient's review of history, that she had suffered from TMD before. Pain in the ear region as well as muscles. To make the long story short, once I adjusted the occlusion, everything subsided. Okay, everything subsided. Okay. And then we watched her carefully for next 2 months until she was completely symptom free in every aspect, endodontic as well as the muscles and the joint, before we delivered the definitive restoration, the final restoration. Okay. Now, her prior history, I'll be right back there, okay, Marlene, and let me just finish this thought process. In context of causative between and contributing, I'm gonna say causative was in this particular scenario at that point was the dental work that the resident did. But she has plenty of contributing factors, right? That contributed to the flare up. Okay. And so oftentimes they can be very blurred distinction, but I think we need to try to focus on where that comes from. And occlusion, in the sense, once you are trained in it, it is relatively easy or not too difficult to identify and correct them. Yes, please, Marlene. Did you want to say
Thank you. I'm
something?
just trying to,
Yes.
yeah, thank you. So would bruxism be a contributing factor then?
I would say bruxism is more of the symptoms of the whole situation in itself, right? So yes, it can be a contributing factor in the sense that if the patient is clenching or grinding, right, they are more prone to developing loose teeth or other aspects that are, you take somebody who already has bruxism and you give them a high occlusion, you're going to have, more likely of a problem in that patient. Now, bruxism is multifactorial. We're going to talk about that later in the book. Okay. There is, still ongoing discussion about, is it physiological, biomechanical, or physiological in the sense it's neurological. And again, that's multifactorial, right? So bruxism, I think, when you talk to the patient, I will oftentimes, if I don't want to talk to the patient too much, I'll just blame it on the bruxism and move on. But bruxism itself has a lot of multifactorial things that we need to think about, that sometimes we have to try to tease away the layers of that onion to get to the center of that situation. But certainly it is oftentimes contributing, if not, I don't want to call that, because that's so multifactorial. I want to say that it is that there is many things that we need to think about on that. Okay, so let's move on. Um, I want to say that it is important that I emphasize that trismus may result from spastic musculature. So if you run into patients, and I'm not suggesting occlusion alone will solve all of the severe TMJ pain patients, okay? But I want you to know from the get-go, if somebody comes in and they talk about severe TMJ orofacial pain, that's with you can tell it's associated with the muscles of the mastication or the joint, okay? And oftentimes that's really trismus or spasm of the muscle. Now, we can say that and then we kind of forget about it, but what's a good example of spasm or even trismus of the muscle? Okay, it is the cramping. Some of you are young and you don't really experience it too much, but you know, cramping of your muscle is the severe form. And if you get a big muscle group like your calf or your thigh, and then you get a cramp in it, okay, it can become acutely, severely painful. Okay, and taking Advil, Tylenol does not help at that point. Okay, okay. Pharmaceutically, only thing that really truly will help will be actually muscle relaxants in terms of prescription medication. Okay, um, and or where they, frankly, injection of the Botox can be helpful, and that's one of the reasons why Botox can be considered helpful for orofacial pain symptom patients. Okay. But, it is important to recognize that spasm is the end result of overworked muscle. If we don't make that connection, then we're going to keep on repeatedly missing that link. Okay? That trismus, spasm of the muscle, is really a cramp, and it is an overworked, tired muscle. Okay? And we have to then figure out why is the muscle so tired. And oftentimes it's because it's trying to avoid occlusal interferences like that figure 8 1-1. Okay. Muscle tension headaches may develop. A lot of times patients will report to you that they get a lot of tension headache, temporal muscles, temporal areas of the head, okay, or occipital region, okay. And then when you palpate those areas, you notice that they'll say, "Oh, that feels tender," okay, and that's because the muscles are overactive, muscles are fatigued, okay. Combination of this, all of those things that we talk about. And then here is the important thing, that is combination of sore teeth, sore muscles, and headaches may cause stress and tension. Absolutely. We talk about stress and tension causing these things, but why wouldn't it be the other way? If you're constantly uncomfortable, would that not increase our stress? Okay. And then constant tension and stress may lead to depression. I've had patients who came to me with orofacial pain, okay, who were literally suicidal. Because by the time the doctor says, they may lead to depression. Okay. And then the doctor starts to saying, use this very fancy word. Oh, this is just psychosomatic. And then the patient looks it up. It means it's not real. It's my brain that's making it up. Well, the patient's experiencing it every day, but then the doctor says it's not real. Well, I think it's totally normal for the patient to start wondering about their own sanity. They start becoming depressed, and then they start losing sleep, and then they become literally suicidal. Okay, you know, so I think Dawson is painting a picture of all the gradual consequences, sequelae that can happen here, right? Okay. And then the next thing is he says the combination of the uncoordinated musculature and the deflected mandible may contribute to a condyle disc derangement. Okay. It's a very fancy word, derangement, which basically means it's not working the way it's supposed to. It's not in a position where it's supposed to, right? So, we will get to that, but we can understand why or how the condyle and the disc, okay, will end up being in a wrong position. They're not working properly because of the poor occlusion, okay? Eventual displacement of the disc by uncoordinated mascatory muscle hyperactivity may initiate painful compression of retrodiscal tissues. Degenerative arthritis changes in the TMJ may follow disc displacement and subsequent perforation of the retrodiscal tissues. All of the above or none of the above. So this is why studying occlusion can become, okay, can become a complex history. But one thing I can assure you is this: it is not as complicated as you may think. Honestly, if I can get it, and I dare claim that I get most of the times, okay, you can certainly get it. You're way ahead of the curve compared to where I was before when I first started. Okay. Now, the next thing I want to emphasize here, okay, so is that is the paragraph after all that list. All of the signs and symptoms listed above can be direct result of the same causative factor, the occlusal interference on the second molar. None of the contributing factors that alter the response actually cause the problems. If the causative insult, the deflective occlusal contact, had been corrected before the irreversible damage occurred, all symptoms would have disappeared without any changes being made in the host resistance or emotional stress level. I want to emphasize this one thing here. I want you to really try to follow every word. Don't take it for granted. He talks about if the causative insult had been corrected before irreversible damage occurred. Thus, before the irreversible damage occurred, if you get to the scene after some of the irreversible damage had occurred, then you cannot expect it to perfectly go back to the normal. There will have to be some sort of adaptive changes that you have to deal with, and which is frankly what happens most of the times with our patients. Okay, and we're not talking about fancy, perforated disc, fancy, displaced disc without reduction. We're not talking about that. That happens too. Okay, but what we're talking oftentimes is what you and I would often consider as a physiological adaptive change. The physiological adaptive change often is, if you think about it, irreversible. And those of you who had heard me talk about it a lot, when you take a look at panoramic X-ray, and occasionally you'll see right condyle versus left condyle having severe discrepancy. You know, the bone morphologic change is an adaptive physiological change. Okay. And yes, it's reversible, but not fully. It's reversible in the sense that you stopped the progression of the pathologic change. So you get rid of the pathology. Now that adaptation hopefully will become more physiological and will become more stable. But it will not reverse back to the original. In fact, human body is such that there is always some sort of irreversible adaptive change that's going on in our body. And our masticatory system is something that utilizes that is utilized probably the most in our body. I often challenge my patients to think about what they do with their mouth, with our masticatory system at age 80 versus when you're at 18. What I mean by that is that if you think about it, there's really no human function. I'm sorry to tell you this because I know, including myself, to my understanding, there is nobody in this group who is at that age 80. Okay. But there is nothing at age 80. Okay. That works as well as, or that works as much as when we were 18, with the exception of the mouth. We can talk as much as we did at 18 without getting fatigued. And we can eat as much as we did at 18 without getting fatigued. We may not be able to digest as much, assuming that you have full set of teeth, one way or the other. Okay? In fact, you probably eat more than when you were at 18. You shouldn't, but we do. Okay? And what I try to challenge my patients to think about is is this, especially if you like to eat hard food. And that those of you who have heard me say, here you go again. Okay? All right. So if you were to imagine I'm lifting up my hand and doing exercise, let's say if I am hanging from a bar, and let's say if I do chin up, okay? When I was younger, let's say if I was able to do 20 chin ups at 18, okay? Am I possibly going to be able to do that? Very few people can do that at age 80. Meaning that our neuromusculature, okay, is not able to do what we used to do at age when we were younger. And yet our patients fully expect to be able to do the same thing at age 80. You know, I was talking to a dentist, a retired dentist the other day, and he said that when he blew out his knee, his orthopedic surgeon told him that forget about playing tennis ever again. You'll be lucky if you can walk normally and walk briskly. Okay. And yet, patients expect to be able to chew just as hard of a food, just as well. And those are the things that we have to be always thinking about, that adaptive change that's going on. That's an adaptive change. Our body is dealing with it, but it is slowly breaking down. Okay. So the reason why I was talking all that is because now Dawson talks about host resistance, how the person is dealing with this causative factor, right? Host resistance, I'm reading now the right paragraph, in the right column, second paragraph. Host resistance is not the only variable. Variations in intensity of the function can dramatically alter the response. What kind of food do you eat? If all I eat is almonds, you are more likely to have your occlusal problem become more magnified. Now, if I have a weak knee and I insist on going out and playing tennis every day, my knee will become a problem much, much sooner. Okay? The same type of occlusal interference can go completely unnoticed by a very relaxed patient who has no tendency to clench or brux. Here's your answer, Dr. Mylene, right? The mouth breather or the person who sleeps with the mouth open will have fewer, if any, above the above symptoms because no stress or tooth damage results in the absence of tooth contact. The same person under duress may begin to clench or brux, activating the muscle into occlusal overload and an avoidance pattern that produces symptoms in the teeth, muscle, and possibly the joint. This last sentence is critical for you to understand. So the same person who had the bad occlusion, when they were totally relaxed, they didn't have any problem with the bad occlusion. But this person is now working 20 hours a day, is mentally stressed out. Now they are responding to that mental and physical stress of working 20 hours a day, okay, becoming a psychological stress. And the psychological stress is causing him to clench because clenching is a normal response to stress. When we get stressed out, what do? We tense up our shoulder. Just as we're tensing up our shoulder, we tense up our muscle of the mastication. Well, there's your clenching. So the host response is just as critical as the bad occlusion. And it is often overlooked. We expect every patient to respond the same way. By and large, they respond similarly. And that's why you have a room full of people and one person with COVID walks in and only few people get that COVID from that person. Not everybody. Okay? So studying of the occlusion, you have to think about causative contributing factors, exogenous, and then the endogenous host response. Dr. Mylene, yes.
Sorry, I'm always asking
No,
questions.
no, no, no,
So
no.
I just
I
want
love it because you and I have few more years of experience than many of these young lads here, and I think it's our discussion that gives them more chance to actually kind of visualize, these clinical situations anyway. So I welcome it. Please.
so stress would be a contributing factor, and
Uh,
is it within our scope of practice to
can you
give
repeat a little louder
recommendations
and
on? Yeah, yes. Here, can you hear me? I don't know my earbud. Can you hear me? Okay. Oh, switching.
Can you hear me?
Yes, I can hear you. I'm sorry, my
Sorry.
internet
No, no, no. I
went
think it
out.
was my internet. But anyway, so go ahead, tell me again. Can you
Oh,
start all over again?
so yes, I was going to ask, would stress be considered a contributing factor? And
Yes.
is it within our scope of practice to give recommendations to the patient around that?
So if I understand you correctly, um, I will say that I will say that stress is definitively a contributing factor. Okay. There is no doubt about that. Okay. There are many, many people that I see. I look at their mouth and I have to scratch my head. How come this patient is not complaining about occlusal problems? Okay. And then there are people who have almost perfect occlusion and they do nothing but complain about all these related issues. Now, how does the stress um, um, relate to that? Either the host response is one thing, where they become more sensitive, their thresholds become lower is one thing, okay? But also their brain becomes more irritated. Besides physiological threshold becoming lowered, okay, people just become much more irritable, you know. So I think it is hugely important that when we talk about occlusion, okay, when we talk about occlusion, okay, um, that we need to recognize that. Now, it is important to the patient that we do not appear to be um, um, blaming everything on blaming everything on stress, because that's like just one step below us telling them it's psychosomatic from the patient's perspective, because the patient, what they hear is, oh, it's my fault. Okay. So so uh so one of the things that I thought that was interesting was here, the next paragraph here. Despite the complexity of the multi-causality concept, it is still possible to simplify our approach to diagnosis and treatment planning if we understand how the musculatory system was designed to function. In the chapters that follow, we will learn how all parts of the system are interrelated in a functional design that is so logical. It will be apparent when there is destructive disequilibrium. That's an interesting word to use. Destructive disequilibrium. Okay. And if I understand Dawson, I think we can probably just use the concept of destructive equilibrium. The reason why he uses the word disequilibrium is because when we use the word equilibrium, meaning we mean like some sort of a hemostasis, everything is stable. And what he's trying to say, disequilibrium, is it's not stable. Okay. And I agree. But destructive means, earlier I was alluding to the fact that human adaptation is not perfect. Occlusal adaptation is not perfect. But our occlusal system, mascatory system, is designed to be adaptive. There is no doubt about it. Without that adaptation, it will not work properly. But that adaptation process sometimes is not stable. Now, I don't want to go as far as to say that every day they are destructive, but I can tell you adaptation process is oftentimes not stable, and that leads to something other than equilibrium. I don't want to go as far as to say they are always so negative that it is disequilibrium, okay? But it is indeed, okay? It is indeed not stable. even though adaptive process. Okay, and that is why those of you, I know that there is at least two of you here that who didn't get to get the articles from me, but maybe I will forward it to you. You know, there are articles that I cite that point to the constant physiological change in our body when it comes to masturbator system. Okay, even without the pathologic, quote unquote, pathologic change. Okay, so I'm gonna skip one sentence and the same paragraph, the last couple of sentences I say, it is not possible to completely eliminate stress, which is true, right? We cannot completely eliminate stress. But treatment planning should always be directed at reducing stress to a level that is not destructive. Ensuring that the total system is in equilibrium is the goal of complete dentistry. So how do I reduce stress? When somebody gets stressed out and they start clenching, how do I reduce that aspect to the system? By giving them a well-fitting night guard. By talking to them about how to manage their stress. It is not uncommon for me to talk to my patients about go join in a yoga class. I tell them, learn to do a little bit of meditation. Meditation is not that fancy, I start to tell them. I tell them, you know, last time I checked, when I thought I was meditating, I was taking a nap. And you know what? That's probably halfway close to meditation. If I'm just not as wound up, you know? I'm sure you've heard many people, many of your colleagues, older colleagues tell you, if you want to be a good dentist, you have to be a half shrink. You have to become half psychologist, half therapist. Unless, even if you're in the busiest dental office setup. So let's say, in America at least, right? If you are working 8 hours a day, a typical productive dental schedule would be, I don't know, 15 to 20 patients. That's really, really busy, right? Right? Most of us will probably be, if you're doing any meaningful restorative practice, okay, hopefully no more than 10 a day, 12 a day. Okay? What's a typical physician schedule? Every 15 minutes. Primary care physician is every 15 minutes. You have to see a new patient. We wouldn't be able to do anything in our office if we had to see a patient every 15 minutes. What I'm trying to get to is that we spend far more time with our individual patients, okay, than any of most other healthcare providers. And these are people who keep coming back to you, not just once a year or every other year. Okay? So by default, you are in a position that you can influence their overall perspective about their health. Okay? Now, you want to be respectful. You don't want to be condescending to them. Okay? Especially those of you who are young. Okay? So you have to learn the art of communication to communicate with these patients in a manner where they don't feel threatened, where they are offended, or they are disrespected. Okay? And one of the best ways to do that, just a simple approach, is you learn to speak to them in a manner is self-deprecating. You lower yourself whenever you can when you talk to them. Okay? And it just becomes your normal body thing every time. Okay, you should become a habit. Okay. Okay. Initially, I used to call all my patients with Mr. or Miss. And now I'm at an age where I can just call them by their first name. But if I, am talking to them with their first name, okay, and one of the ways to easily be self-deprecating to them is I introduce myself as not Dr. Lee. I'll tell them I'm Tom. Okay, puts them at ease. If they choose to call me Tom, that's fine. Very few people will do that if they are reasonably educated. They'll still call me Dr. Lee. Okay, but I put them at ease. I already successfully communicated to them that I'm not a, you know, holier than thou kind of guy. Okay. So, if they get confused, then you go like, "Oh, I'm Tom. Oh, I'm sorry. I'm not the front desk. I'm not good at that. I'm not the chairside assistant. I'm not the hygienist. I'm the dentist." Okay? So there are many different ways that you can communicate to them how you view your relationship with the patient. That it is a co-working relationship. It doesn't mean they pay you less. Just because they call me Tom doesn't mean that I bill them less amount. Okay? You don't have to insist to your patient that you want to be called the doctor. Okay? And that's a very good communication skill. Okay? So it is important that I'm sorry, where was I? Okay. Let me go back to the I sort of lost it where I was. Okay. Let me just start out from here and saying, okay, that on the right hand side, I find myself um, about halfway down. I think I was there before. I think I read this sentence before. It is very popular. It is a very popular concept to blame emotional stress for many of the disorders that are, in fact, caused by structural disequilibrium. Okay. None of the patient responses listed above would have occurred if the deflective incline on the high tooth were not present, regardless of the patient's emotional state. That's exactly the point. Their stress and emotional state um, amplifies their situation. However, it would not have uh, manifested itself as a toothache, as a joint pain, as a muscle soreness, if they did not have that high spot on number 1518. Their stress could have been manifested as lack of sleep alone. Their stress could have manifested itself as just being short tempered or becoming more diabetic because they keep eating. Okay? So remember the weakest link. So, what is the weakest link in that person's system, body, when they get stressed out? We want to make sure that occlusion is not that weakest link. Okay. This is not to say that emotional stress cannot result in pain or discomfort. What is important is that it is possible and practical to isolate structural causes for pain or dysfunction and correct those causative factors. I couldn't agree anymore. Okay? You want to address the stress on its own, you want to help them, but you know what? We can't give them Valium for their 24/7. I talk to my patients about a lot of variety of different health effect things because of this issue. I will talk to them about, for example, if you're interested, there is a book called, I think it's called Dopamine Nation, something like that. That Americans are so hungry for dopamine. And dopamine is what? That hormone that makes you feel good. makes you feel motivated. It's usually associated with something that's positive. But Americans are so addicted to that positive reinforcement. They're constantly doing that. And guess what? That's how people become addicted to drugs. You have to keep on one upping, upping, upping. And I have to tell my patients, slow down. You know, the traditional wisdom of not being so high, okay? Bring down your baseline in everything we do, including how we eat our food. I keep telling them, you can eat your nuts and almonds once in a while, but don't be eating them every day. If you're going to eat them every day, probably no more than 5 a day or something to that effect. Why? Because it's like playing tennis every day and you wonder why your ankle and your knee and your elbow hurts. Okay? Experience has also shown that when pain or dysfunction is eliminated, emotional stress is relieved in many patients. It appears that psychosocial stress is often a result of rather than cause of orofacial pain. So now this is a very distinctly different opinion than many of the people's orofacial pain training. Okay? Because they want to have that totally separate, or even to say that psychosocial stress is the cause. Okay? Patients lose their teeth in two ways, either the teeth break down or the supporting structure break down. As simplistic as it may sound, if we exclude neoplastic disorder and specific pathologic conditions, almost every deteriorating effect on the teeth or supporting structure is a direct result of one or both of the two causative factors. Stress from microtrauma or physical injury, macrotrauma, or microorganisms including gingival disease of specific bacteria, viral, or fungal origin. Stress from microtrauma results from repeated occlusal overload. That's what we're going to probably focus on for this book. However, diagnosis and treatment of occlusal disharmony will be discussed in detail throughout the remaining chapters. As factors of occlusal overload are better understood and the destructive evidence of occlusal disease is better recognized, there is sometimes a tendency to downplay other equally important causes of deterioration. The role of microorganisms must always be given a high priority in every dental examination and treatment protocol. The role of microorganism. Now, I don't want to emphasize too much here just because not because I'm not saying it's important, but this is probably all of you are just as well aware of it as I am, if not more. What I just want to emphasize is this, okay? That nobody's mouth, and this is a very broad oversimplification, but I think it warrants being told. Nobody's mouth is sterile. Everybody's mouth has bacteria in it. Primarily the periodontitis model that we're going to talk about. Okay, why is it that only some teeth, oftentimes, will have a much more acute breakdown? That's what Dawson is primarily focusing on here, okay? And that is, it is the presence of bacteria layer on top of it with acutely bad occlusion, okay? That leads to this problem, okay? He talks about occlusal trauma and pocket formation. If you want me to read into this more, I'd be happy to. And if there was any specific section of this that you thought that you want to discuss, I'm happy to talk about it. But I think the gist of what he's saying is this, and he talks about, he talks about the I think the interleukin 1 beta, okay, and how that becomes osteoclastic in action, okay. So this is something that I've suspected without using those words, and that is this: that you could have teeth that are mobile from hyperocclusion, okay, fremitus, without having deep probing depth. It's almost as if the whole periodontium, alveolar housing, just becomes weak, okay, widen PDL or whatnot. At that juncture, if there is no breakdown of the sulcus from top down because of the bacteria, if you control the occlusion, most of the times your mobility will get reduced. I have personally have experienced most of the times as much as +2 mobility, getting down to plus mobility range. Okay, not just one time occlusal adjustment, you have to remember several times. Okay, if there was no deep probing depth. But what he's saying here is this interleukin on osteoclastic activity can weaken the PDL space, lamina dura, and the alveolar housing from bottom. And then if you have bacteriological breakdown from the sulcus going downward, and when they meet together in so many ways, okay, that's when you're going to have a runaway periodontal breakdown, localized. Now, it is entirely possible you can have only top-down breakdown or bottom-up. Absolutely. But most of the times, especially when you see in our patient's mouth, when you see pockets of second molar going bad, bicuspid going bad, and this and that, it is usually those two factors that are acting independently initially, and then they meet, and then they become that problem. A long time ago, one of my good friend, well, at that time he was a good friend. Now he's sort of mad at me, but he's a general dentist, and he was saying this. You know, he's actually he's somebody who made a lot of money in dentistry. That's about where I will stop by running a company, but but he said something to the effect like this. He said, "Tom, think about it." And you know, so even though I was a prosthodontist, I was young in my career, was probably about good 10, 15 years ahead of me. Okay. And he goes, Tom, think about it. If you assume somebody had perfect occlusion, if you assume somebody had perfect occlusion, but you now have pockets of periodontitis, even if it's just gingivitis, okay? What is the definition of itis? That means inflammation. If you give somebody periodontal inflammation, alveolar inflammation, is the occlusion going to be perfect still? No. So even if you assume they have good occlusion, the fact that they now have periodontitis, even gingivitis, okay, most likely would mean their occlusion is not as perfect as we would have wanted it. So what he was telling me as a general dentist, he was telling me, if you want your perio to become stable, you have to look at occlusion. You have to make sure that occlusion is no longer traumatic, whether it's primary trauma or secondary trauma, whether it's macro trauma or micro trauma. Without controlling that, you cannot expect the periodontitis, periodontium, to become healthy. And if the periodontium never becomes healthy, can you expect the occlusion to become healthy? No. They go hand in hand. So if you want to be a good restorative dentist, you have to be in tune with perio. You have to be able to work well with periodontists. You have to at least be astute in recognizing periodontal problems, how to diagnose them, and how to improve them. I hope that makes sense to you. Okay, I don't want to be stuck in reading everything. So I'm gonna stop here for chapter one. I hope there is no protest. But if you wanna have, if you marked something, okay, then please raise your hand and let me know. Okay, the last paragraph of chapter one on page 9. Okay, it this is now wrapping up after talked about, he talks about anatomic harmony. Okay, is actually I'm sorry, these the highlights just jump out at me when I try. So chapter 9 on the left column, second paragraph, it says there are many so-called physiological malocclusions that are stable and function well. They do so because the cumulative effects of difficult dynamic factors produce a stable result, even though it does not fit the class 1 stereotype of classically correct occlusion. I want you to remember that. Okay? I want you to remember that you don't need to have class 1 occlusion to have stable occlusion or physiologic occlusion. What he says, physiologic malocclusion is fine with me. I don't like that word malocclusion. I would have preferred that you can have physiologically stable occlusion other than Engel's class 1 occlusion. Okay? And then I would like to say that blah, 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 blah. The last sentence of that paragraph, he says, we may subject our patients to unnecessary overtreatment or inadequate undertreatment if we attempt to treat signs or symptoms without knowing what caused them. Okay? Um, and then the very last paragraph, it says, the first sentence, the goal of functional harmony is a peaceful neuromuscular system. The neuromuscular system is indeed, okay, what we're trying to, sort of tame here in terms of mastication. I'm sure that some of you may have remember reading. I forget exactly where in but one of the chapters, pages, Dawson talks about, if the muscles and the teeth fight, who wins? Muscles. Okay, even the bone actually. Let's go to chapter 2. Any comment? No, we're good. If you're not asking for, oh
Doctor,
yes, Marlene.
I have a comment. I have a quick comment.
Yes, please.
So the non-carious lesions like the abfractions or the recession, in
Go
the
ahead.
root exposure, is that due to mobility or occlusal
Actually,
disharmony?
you're getting ahead. I know that there is a section he talks about that when he talks about chapter 3, occlusal disease, right? So I don't want to just say we'll talk about it at that point. What I will say is this. When I explain to people, I disagree with Dawson about his notion about effraction. Okay. Just like what he said about multifactorial, I do believe effraction is multifactorial. I don't want to say it's only occlusion. Okay. And I think he oversimplifies it when he talks about overload. Okay. But just so that I answer your question, effraction actually occurs more when there is less mobility. You can have both effraction and mobility, yes, but oftentimes you will see effraction, both buccal and lingual, on teeth that don't have a lot of mobility. And that is actually part of the total understanding. Remind me to talk about that a little bit more. Okay. my connection went in and out again there. Sorry about that. I'm sorry. I said my connection went in and out there. Okay. So let's just kind of go over to the page number 13. Okay. And then I know that we're going to talk about this section here on and off, but I wanted to give you some level of confidence. So that's why I wanted to, the second paragraph, no, I'm sorry, left hand column, one, two, three, fourth paragraph. Third paragraph in the subsection of relevance of occlusion to everyday dentistry. It says, the disparaging of occlusion as an important part of the daily practice has become so pervasive that the National Institute of Health and the National Institute of Dental and Craniofacial Research published a pamphlet to advise the public that occlusal adjustment or any other irreversible occlusal treatment for temporomandibular disorder is of little value and may make the problem worse. And that is true. Actually, I have actually um, um, Googled it, and I saw that sign myself. That is based on, often, unfortunately, a lot of literature that's out there. And I'm not trying to badmouth anybody, but a lot of literature that relates to the occlusion and orofacial pain. The research are done by clinicians who are who are not really restorative dentists. Okay, those of you who can hear me, I'm gonna actually shut down my video just because I think my video feed and many windows open may be the reason why my internet might not be I'm exceeding my internet thing. Okay, so I'm gonna just close my video. But and if all of you wanna, usually I want my video to be up, but for some reason it's having this problem. So let's just go ahead, and if you want to turn it off, I'm fine with that, so that we can have more continuous I at least a voice. Okay. And then if I wanted to share possibly a little YouTube video later on, so we'll get to that when we share. Okay. But one thing that I wanted to say about NIH perspective and what's out there on Google and this and that is this, that um, let me just kind of read this book, and then maybe I can add to it. Okay. The next sentence, it says, further admonitions that recent research disputes the view that bad bite can trigger TMD, provokes distrust of all forms of occlusal therapy. A profuse amount of seriously flawed literature supports this viewpoint and denounces all alterations of occlusion as an unacceptable choice of treatment. Limiting judgment of occlusal principles on such a narrow focus as its effects on TMD distorts the true value of occlusal harmony as a realistic treatment goal of many different problems. I'm going to skip over the paragraph, and then the last paragraph on the left-hand column. It says the NIH admonishment that occlusal treatment is of little value and may make a TMD problem worse may be true if it refers to inappropriate occlusal changes that are representative of the lowest common denominator of treatment. So he sort of gets to this here, where I wanted to emphasize this. A lot of the research that are published as it relates to occlusion and orofacial pain are done by people who specialize in orofacial pain. And with all due respect to many of my colleagues in that field, they do not practice restorative dentistry. If you don't practice restorative dentistry, okay, how good are you gonna be in in observing and diagnosing occlusal problems. Okay? That is I mean, and it's a sincere question. I'm not suggesting that I look down at them, but all of you have been in restorative dentistry enough where you know that many times looking for that one spot that makes the difference in patient telling you, oh, that feels better. That takes practice. And that's with all of us doing restorative dentistry on a daily basis. But these orofacial pain specialists, they no longer do fillings. They don't have patients that you do the fillings or crowns and then have these people come back and tell you that it bothers them, that it's getting sensitive, and that you do adjustment and that they get better. They no longer have that experience. Okay? They no longer have patients who tell them, yeah, initially at first it was that one tooth, but now it's everywhere. Or now my ear, my jaw hurts. By the time that these orofacial pain specialists see patients, it is oftentimes cases that have far progressed forward. That's number one. Number two, that there are many, many different layers of stress and this and that that had been added on to their condition. Okay? The patients have hard time discerning. So, they mean well, okay? But when people do not do something every day, it doing something every day does not mean that you will always become perfect at it, but it does make it easier if you do practice it every day. Those people who don't practice something every day, the challenge is much, much taller for them to become really good at it. Okay? So that's number one. Number two, Dawson also makes another very good point. Page 13, on the right-hand side, third paragraph. When the NIH position states that research refutes the view that a bad bite can trigger TMD, the statement fails to test for scientifically accurate conclusion. A truly scientific study must ask, what kind of TMD? TMD is not a single disorder. Those of you who have taken orofacial pain classes, you all know that, right? It is not even a single multifactorial disorder. There are many, many different disorders or types of disorders that get lumped into orofacial pain or disorder. Okay? And yet, and NIH is the first group of people who will tell us that we need to be deliberate in our wording of these things. And yet, they make the same mistake. Okay? So I wanted to empower you, knowing that despite quote unquote what evidence-based dentistry seems to tell you, okay, that I want you to know there's plenty of literature that's out there that also points to occlusion having intimate relationship, if not causative relationship, to many of the orofacial region discomfort pain besides teeth. And that we as restorative dentists are in the best position to be able to help these people. Okay? Oftentimes, oftentimes that that the so-called specialists who pump out paper after paper, with all due respect, they're not even clinicians, period. They're more of researchers or lecturers in a sense that they are in academic institution, they're giving lecture after lecture. But that's a repetition of a knowledge that they're familiar with, from just from one small sample of literature out there. Okay, so I wanted you to just know that as we are making the first steps in understanding occlusion, that we are not going against evidence-based dentistry because that evidence is slightly distorted. Okay, there's editorializing of that evidence. Okay, the last paragraph on the right-hand column on page 13, scientific analysis also demands a much improved explanation that more clearly defines a bad bite. Absolutely, and requires characterization of malocclusion in more descriptive term. The use of Engel's classification of malocclusion as this to describe arch-to-arch relationship or to define malocclusion is perhaps the most consistent and serious flaw in the literature that disparages the idea of a relationship between occlusion and TMD. The cause of confusion is self-evident because Engel's classification does not relate maximal occlusal contact to either the position or condition of the TMJ. It's absolutely true. When you go back and take a look at orthodontic lectures that you got for Engel's classification, okay? Basically, it's literally made on a upper and lower cast model or patient just biting down on their own. And then you just look at teeth relationships. You do not have any concept of where the joint might be. The joints, rather, TMJ joints. Okay. Use of a classification system that ignores any relationship between occlusion and the TMJs can hardly be considered an analytical model for studying the relationship between occlusion and the TMJ. A search of the literature confirms that this serious flaw has been consistent in a profuse amount of reported studies that are cited to discredit the value of occlusal harmony as a treatment objective. So, Engel's classification, if you talk to orthodontists, they'll just pull out a model, upper and lower model, and they'll say, oh, this person has class 1 occlusion, that's fine. In fact, almost every orthodontist wants to just make everybody into class 1 occlusion, regardless of what the TMJ looks like. Once they have done the analysis, most of them don't even take TMJ series, which I frankly don't think is necessary all the time. Okay, they don't really track how the TMJ is doing as they're going through orthodontic treatment, the progression. Okay, so, but as you, the restorative dentist, know that depending on how the patient moves their jaw, their occlusion can have a very profound change. And that's what we have to try to emphasize and understand. Okay. So, um, so let's just go to page 14. Okay. I'm going to go to page 14. Okay. Hold on one sec. Okay, Marty, I just got your text. Thank you. So, let's just look at let's finish this chapter. Okay. Um, on the left-hand column under the subtitle of diagnosis of oral facial pain in general practice, the variety and vagaries of pain from dental origin are complex. Origins are complex enough. By interrelationship between TMJs, the teeth, and neuromusculature require special expertise to evaluate the diversity of signs and symptoms that can result from structural disorder within the system. Okay, blah, 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 blah. So, if I may share with you the way that I approach this is this. If I have somebody who has joint pain in TMJs or muscle pain or have been told by somebody else, okay, what I will do is I will do what your dental school taught you for full occlusal evaluation. Try to look at what's the initial contact point, CR, full maximal intercuspation, CO, any slide, travel direction. I look at hurting. If they have maximum opening, that's normal. I think I was cut off there again. I think I'm gonna have to figure out a way to do a wired internet to my laptop in my office. I'm gonna do that. Okay, for the next visit. I have been having some my Wi-Fi issues here. But what I was gonna try to say was this. I don't know where I got cut off. Is this that I do my complete examination, including palpation of the muscles and opening and closing of the jaws and everything. And I look at the CRCO slide. If the patient has positive pain, and then I can palpate their tenderness, and then if I see there is occlusal problem, such as CLCR slide, you know, deflected point contacts, traumatic occlusion, and things like that. Then I feel confident telling my patient there is a high degree of chance that they are related and that addressing the occlusal issue will most likely resolve your problems. And when I have that approach, I'm gonna for my 30 years that I've been done with my specialty training in prosthodontics and approaching this topic with occlusion. I'm gonna say my success rate is 99% plus. Once I confirm patient symptom and my occlusal analysis and positive pathology and occlusion related findings. Okay, if I see that they are both present, and if I tell them we can approach this with splint therapy night guard or mandibular deprogramming stabilizer, okay, then they almost always resolve. Now, the cases where they did not resolve, okay, are cases where most of them, frankly, the patients did not come back to me. Is it because they got disgusted at me because it didn't work, or they were satisfied? Who knows? Another one, I have two cases over the years where I controlled everything, but they didn't really have any pain that much anymore in terms of joint pain or whatnot. But there's two people that I'm thinking about. They continue to have clenching to the point where they had dental pain, even though they were wearing a night guard at nighttime. And I really frankly couldn't find anything more improvement that I can bring to them with their teeth occlusion. So I went ahead and I said, okay, you know what? I think at this point I'm out of answers. If and I don't want to tell you to do a full mouth rehab because I don't see enough. I'm okay if you start using occasional Botox if that gives you predictable relief from symptoms. Okay. So, but what I want to really emphasize is I don't do a voodoo hunting. Okay. I want to make sure that there is something that I can see with that what I call occlusal discrepancy that I think that will improve the chances of me controlling everything that my patient has. Okay. I do not just kind of go on a random thing if I'm not able to visualize the aspects that I can improve in the patient's occlusion. Okay. Okay. So I pretty much talked almost nonstop for 2 hours. So why don't we go ahead and take a little break time here? Um, um, and if those of you who are still with me, occlusal disease, and I think Dr. Mylene was talking about this right here. Okay. So I think this is now where like, okay, this is like stuff that we're more familiar with, right? Okay. So I'm gonna sort of kind of skip through, not skip through, but unless you have any questions about it, I'm gonna have you, stop me. Okay. But let's get to that abstraction topic because that is something that there are a lot of different opinions out there, and this is the first topic in this book. Remember, I told you I choose Dawson's book not because I agree with everything. I'm not a parrot for Dawson, okay? But I think he talks about a lot of different things that bring up an occasion, opportunity for us to discuss. That's why I choose this, right? So, so right now, for example, the first topic that we're going to have some discussion, the different opinions on, would be this abstraction. So let's talk about that. Page 19. Okay, page 19. The bottom of the second hand column. Okay, the role of occlusal overload on non-carrier cervical lesion has not been as incontrovertible as many have assumed. By Lee and Eco. Unfortunately, that Lee is not me. It under occlusal overload. Okay, so that is superscript number 7 for reference. I always like to at least, if there's an interesting topic, I always like to at least take a look at what journal and what year that was published. Number 7, it says Journal of Prosthetic Dentistry rather, in 1984. So that's when the term was first started to be described. And he said Grippo used the word abstraction, and reference number 6 was published in Journal of Aesthetic Dentistry in 1991. So if you think about it, these are relatively recent discussions about this. Okay? So Uh, I'm gonna I'm gonna try to because I do want to try to get to also a case that Marty prepared, but um, the same paragraph on the right hand side, first paragraph about halfway down in the middle. First paragraph in the middle, it says numerous investigators have claimed that occlusal loading forces do in fact cause flexure of teeth that produce microfractures and structural loss in the cervical area. Further studies indicated that acid penetrates microcracks and undermines the tooth surface that are then more susceptible to mechanical deformation. And then he goes on to say, Dawson goes on to say, I must admit that I was one clinician who accepted the validity of effraction as a result of occlusal overload. I have had to rethink that position in light of some convincing data to the contrary. Abramson, now he is citing Abramson as a reason why he's changing. So that's number 13 reference point. 13, it says 2005 now. Now he's recognizing paper that was published in 2005. It says, has demonstrated several inconsistencies to the occlusal overload theory. Since I consider Abramson to be the foremost authority on occlusal wear and recognize that he is a prosthodontist with an in-depth understanding of occlusion, I feel his analysis is worthy of my consideration. It is also consistent with the current research done by Zakovich, which leaves little doubt that the so-called abfraction lesions are not the result of occlusal overload, but rather caused by toothbrushing with toothpaste. And that is reference number 14. And so Zakovich paper was in 2006. Okay. Now, so in a very over abbreviated process, we just talked about bending over the teeth to the erosion to the toothbrush and toothpaste. Okay. What I would like to say is this: just as Dawson said that we read a couple of hours ago, abfraction also is multifactorial. It does not have to be only mechanical load and bending of the teeth. It does not have to be only erosion from the acid. It does not have to be only the toothbrush tooth abrasion. It is a little bit of everything, all of them, but added to that, strong alveolar bone. For the biomechanical model to work, it's not just an occlusal overload. It's the lateral loading, if you are looking at me now, lateral loading of the teeth that causes flexure of the tooth. If you're straight on occlusal loading, there is very little that the tooth has to flex, right? But if you're causing the flexure, that means you're loading sideways of the tooth. So if you want to say that's an overload, that's not descriptive enough. You can have an overload that's vertical overload. You can have a lateral overload. Okay? Why would some lateral loading be overload versus not overload? If the lateral loading does not cause the tooth to flex so much or cause mobility, okay, if it does not cause that, then that is probably not an overload. But if the loading is so significant that is causing mobility because the alveolar bone cannot withstand that load, or the alveolar bone is so strong that it's holding onto the root really, really tight, which causes the tooth to indeed flex because the root's not going anywhere. Yet the coronal portion is consistently loaded. Now, if when the coronal portion is consistently loaded, if the bone is not that dense, if the bone is not that strong, then the bone will give. Then your tooth is not going to flex as much. If your tooth does not flex as much, then it wouldn't be subjected to abfraction type of lesion as much. Why do I say I don't subscribe to only toothbrush and toothpaste theory? is because if that were the case, you would not see abfraction only in one tooth in a sextant or quadrant of an area. Forget about the whole mouth, because then you can talk about right hand versus left hand. I don't even want to get there. Okay? Why is it that in so many patients you would have an abfraction that occurs primarily on number 12, but not on 13 and not on 11? If it was tooth, don't tell me that my patient's only picking on number 12 with a toothpaste and toothbrush. Don't tell me that acid is only, accumulating only on number 12. That's not happening. But it is easily testable for us to see. And indeed, we see that repeatedly over and over. Okay? Where one particular tooth or few teeth have that specific lateral loading. But when you're checking that lateral loading, you got to make sure that lateral loading is not only real there on number 12, but that is not a consequence of deflective mandibular movement from hyperocclusion on number 2 and 31. If you miss number 2 and 31 and you only go after number 12 and number 21, then you're not going to be able to full or lateral deflective movement and therefore lateral loading. Okay? So this is what I mean with all due respect to Dawson. And he's got a lot of people helping him write this book. He's passed away now. I don't know if you knew that. Pete Dawson's now in heaven. I guess occlusion heaven, I guess. All right. So 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 I have tremendous respect for him. Absolutely. I learned so much about what I know about occlusion from his book. Okay? But nobody is perfect. I'm not perfect. Nobody is perfect. Unless you're gonna say you are God. Okay? So to me, he's the first one who told us at the early onset of the book. He said everything is multifactorial. And yet he's committing the same crime here. He does not see this particular aspect of occlusal problem as a multifactorial, and which is what I want to emphasize to all of you, that you see this problem as multifactorial problem. Yes, Dr. Miley.
I a couple things I was wondering if you could
Yeah,
enable my
can you hear me?
video and then
I
yes.
see your
Can you
hand
hear me?
raised.
You can't hear me? You
I
can't. Oh,
think are you muted
can you hear
or
me?
are you? I don't think so, but somehow I'm not able to hear you.
No,
We can
no.
hear you.
You can hear me?
Is
Yes,
it
I
me?
can. I can hear
Can
you.
somebody else speak so that I can make sure that I have I am connected? Because everybody went to
We can hear
the
Dr.
monitor
Miley.
free, so my camera list. Okay,
Okay,
so
thank you.
did you
Can
want to
you
say
hear me
something, Mylene?
clearly? Yeah. Um, I don't know what to say.
Hmm. I
Can't hear
can't hear
me?
you. Sorry. I don't know if other people can, but I'm gonna move on.
Yeah.
On if you can speak, feel free to just jump in.
Can
Okay.
you enable my video?
Oh, you can hear Mylene, but I'm not able to hear Mylene. Okay, I see. Hold on one sec. Maybe was I didn't mean to cut you out when I closed out your
Oh,
video. I was just trying to save the bandwidth.
no worries. Can you hear me?
Oh,
You
you
can
know
hear me
what?
now?
I got it. Ha 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 ha. I didn't have my headphone for until now.
Uh,
Okay, sorry.
right? That's
This
good.
is this is what I mean. We're all just like anyway. Okay, group
That's hilarious.
group group effort. Thank you. Okay, go ahead.
Yeah, no, what I was gonna say is Okay, so are there current research articles on the effects of lateral interferences and abfraction and recession?
I cite one study I did as a not I did I did as a literature review in my article. If you'd like, I can send you the it that was a because they were saying like there is no like evidence or whatever. So this one group of guys, they have done computer modeling, finite element analysis of of the balancing interference leading to weakening of the buccal molar DEJ area that leads to the or abfraction. So
And because
that's not the most recent, but that was done some time ago. But that is, for example, a study out there.
and because also about the recession,
Mhm.
like root exposure and lateral interferences.
So here's what I say to that. So yes, so gum recession is oftentimes, we all agree. I hope here that that you can have gum recession without periodontal disease. Okay, that it could have been a history or you just never had it. That being said, you have to keep in mind that if somebody starts out their life with thin biotype. Okay, thin biotype, which means they have thin gum tissue, thin bony buccal bone. Okay, what would be considered a physiological lateral loading will overwhelm that periodontium, and you can get gum recession. And once your dentin is exposed, then you are much more prone to having abfraction lesions, whether it be erosion type, whether it be toothbrush abrasion type, or even occlusion type. Okay? So I would like to have all of you think of that as multifactorial. Another example of multifactorial that I wanted to share with you on this in this chapter is page 21. If we look at page 21, I one of the reasons why I like this book as I'm lazy is that this book throws at you a lot of pictures, right? A lot of pictures. So so he talks about attritional wear, and he gives you this photograph of A, okay, A and B, okay. Talks about how he's blaming the opposing dentition restoration for the destruction of the wear. I mean destruction, right? Okay, and you can see certainly it can become much more significant that way. Okay, but I'm gonna say to you this way. Okay, you've seen plenty of cases where there is no opposing quote unquote restorative material. It's just enamel to enamel or dentin to dentin, where they can have that type of wear and tear of the attritional wear. So why is that? Okay. Again, I'm going to point to occlusion. So if you look at picture B, number 8 does seem to cause more wear on the opposing. That's number 8 is PFM, right? But number 9 is a chipped away enamel, and that's still causing its degree of attritional wear in the opposing. Okay. Now, do you always see attritional wear in your patients where they have PFM or zirconia? Because people are all worried about zirconia. No, not really. You don't see that all the time. So when do you see it? When those teeth are in hyperocclusion, much more so, at least. So once again, I want to just reiterate to you, more than anything else that I know, well, just as much as anything else that I know, occlusion, factors related to occlusal diseases are multifactorial. Okay? They are multifactorial. So the way that I explain to my patients is like this about effraction is that I say you start out with occlusion, teeth that causes your teeth to be bumped sideways and they are getting overload sideways. And then you have very strong bone that is not yielding to your occlusion. So your teeth are forced to be bending, flexing. And then you have some gum recession that exposed your dentin, your cementum, which is more flexible part of your tooth and much more susceptible for erosion from acid, from either plaque or food or juice, and abrasives of your toothbrush and your toothpaste. You can mix and match any intensity amongst them with each other, so one can be more than the other in any particular individual. But to a degree, a certain degree, every one of them, of those aspects that I can think of, is at play. Okay? And same thing with restorative materials. Okay? So now, when we are looking at these examples of occlusal disease, you are looking at all these things that are, wear and tear. You can see it's clear that sometimes that it is that obvious that opposing did not have any meaningful restoration. Okay, page 22, picture C. Okay, I guess that they didn't put down C, huh? Okay, but the third picture in page 22, okay, I'm going to look at um, the tooth number, I'm going to call that 11, okay, opposing the lower. So you can tell 11 has a little bit of effraction, okay, and then it's look at the wear and tear is causing to the bottom. Now, to me, okay, when you look at this picture on page 23, A, he blames that on anterior guidance attrition. Okay, and it's very possible it is anterior guidance attrition, but I'm going to say most likely add to that, especially when you look at the wear pattern of the number 8 and 9. To me, that's not just guidance. That's actually traumatic occlusion. And I'll explain to you why at a later date. Okay? So now, I don't want to be painting a picture where everything just becomes blurred because everything's multifactorial. I don't want to confuse you on that. Okay? And I don't want to say, oh, it could be this, it could be that, or whatever. Part of the thing is that it is indeed rarely A is equal to B. Okay? And you need to have an open mind about how to pursue different things at the same time in terms of trying to resolve the occlusal problems. Okay? So these are things that we had talked about before, more or less, from previous chapters. So I'm going to kind of go over, okay? And just quickly, sensitive teeth, sore teeth, hypermobility, you can see that. And then fractured teeth, okay? Painful musculature. All those things we saw before. So I'm going to just skip over that. If you didn't get a chance to read it, please read every sentence. Make sure you understand the author's every sentence before you move on. It's not a lot of reading, right? After all, you're reading this not for an exam. You're reading this to become a better doctor. Okay. Now let's take a look at chapter 4. This is really important before we go on to chapter 5. Okay. Chapter 4, determinants of occlusion. Okay, now he's got this fancy drawings and pictures and all that, and we can sort of spend time reading it, but he does actually very nice illustration here. Okay, so I'm gonna just kind of go through this picture by picture, starting with page 29. Okay, Page 29. He says, you start with the socket in a fixed bone. Yeah, your glenoid fossa. So your home base for your occlusion is your maxilla, or rather your base of the skull, where the glenoid fossa is. Okay, because as far as our mascatory system is concerned, okay, our skull is the immobile base. Just the opposite of the articulator that we are subconsciously ingrained into our brain. It is not the top that moves, it's the bottom that moves. Okay, so we start out with the top jawbone, and then we add bottom jawbone. Okay, those two are the basic fundamental skeletal tissues that we're going to be dealing with, right? Upper and lower bone. Teeth are, as you know, if you read this chapter, teeth are the last part. Okay? Now, as the lower jaw moves back and forth, there's this issues with airway space, there's issues with even spinal cord and maybe even hyoid bone, all kinds of different things that that is related to that. So they're saying if the mandible only rotated, you're going to have all these problems. So mandible has learned to dislocate itself and translate forward, slide forward, and that's where we have anterior movements of the mandible. That's the fourth picture. Okay? And this is the incredibly good part and complex part of our jaw. Our jaw, lower jaw, is not only able to rotate up, rotate, open and close, it is doing that and while simultaneously going forward and back at the same time. Now, there's one more picture that I wish he would have thrown in here, but I'm sure he doesn't want to confuse it too much. Okay? When your jaw is going forward and back, okay? It does not necessarily move right and left at equal timing. In fact, if your jaw goes sideways, okay, if I move my jaw to my left, okay, then what ends up happening is my right condyle goes forward and my left condyle goes backward. It has slight rotational ability even to the horizontal plane. Okay. Now, in order to allow all these movements to occurring very smoothly, okay, there is that disc there. And then in order to hold that disc assembly tightly, there is the ligaments there. And then in order to enable our brain to move our jaw the way that we want them to move, there are the musculatures and the neural innervation, nerve innervation. It is obviously clear to all of us when you look at infants as well as totally edentulous patients. The fundamentals of jaw movements are all there without any teeth. Teeth come in last. And that's the irony of it. And this is where I'm going to talk about later on, where so many dentists are thrown off. And then so many people talk about canine guidance and anterior guidance overriding this whole mandibular movement. But those are the last things that came in. The jaw is fully capable of moving about without having anterior guidance and canine guidance, without any pathology. Okay? So I hope you understand the importance of seeing it this way. The teeth are the last pieces. Now, as dentists, we deal with that just primarily teeth or how they interact with each other. But seeing all this connection, we have the ability to influence directly or indirectly to all this structure. And that's how we control and help our patients. Okay. Now, on page 31, he talks about primary requirements for successful occlusal therapy, figure 4-3. I'm sorry, before I get to that, just to reiterate, okay, on page 31, left-hand column, under the little box of principle, so let's read that principle. It says, determination of the correct physiologic jaw relationship must always be determined before we can determine the correct alignment and occlusal relationship of the teeth. Yes, what he's saying is understand where the bone relationship is first before we do the teeth. Okay, and then the sentence right after that, the teeth must fit into the harmony of the jaw relationship, not vice versa. But I'm going to remind you about this sentence from Dawson when he keeps telling you about how he wants anterior guidance to control jaw movement. What gives? Now, I'm not suggesting anterior guidance is always wrong. I'm not saying that. But anterior guidance is oversold, overpromised. It is certainly not a panacea when it comes to dental occlusal problems. And that is why so many of you and so many of our colleagues are confused about occlusion. They read the same book, and yet all they remember from Dawson is anterior guidance. And yet it is Dawson himself says teeth must fit into the harmony of the jaw relationship. Okay? So now, the second part. So on the right-hand column, primary requirements, and this is why just that one sentence, for example, is the reason why sometimes I have to read the book to reemphasize to you. Because I don't want you to have missed that part. To me, if you miss that part, and if you only remember anterior guidance because he talks about it in 3 different chapters, to me, you missed the more important part. So he talks about primary requirements for successful occlusal therapy. Okay, number 1, comfortable and stable TMJ. By now, we go like, at least conceptually, okay, we want the bone relationship to be comfortable. Okay? All right. Number 2, he says anterior teeth in harmony with the envelope of function. So he says anterior teeth in harmony with the envelope of function. Anterior teeth in harmony with the movement of the jaw. Not anterior teeth controlling the movement of the jaw. And yet, if you look at the definition of anterior guidance, canine guidance, what does it say? Or at least popularly said. I'm going to define anterior guidance differently later on. Okay? Okay? You have heard so many people tell you, you give your patient strong anterior guidance, canine guidance, and you force them to become vertical chewers. And you're going to solve their problems. And yet you do that and you realize, oh, damn, it's not working. Why is that? Because anterior guidance has to fit within the envelope of motion, within the way harmonious relationship of the upper and lower jawbone, as dictated by the muscles and the joints. I raise my voice because this is the part that people just keep getting it wrong every time. Even the most smart people They just keep getting it wrong. When they read this book, they say the teeth must fit into the harmony of the jaw relationship, not vice versa. They just skip it. They go, yeah, 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 yeah. And they just laser focus on anterior guidance. Okay? Sometimes the secret to the success comes to you so softly, nonchalantly. You miss what just hit you. To me, that sentence is much, much more critically important than 3 chapters that Dawson essentially devotes to anterior guidance. Okay? And then the third one is non-interfering posterior teeth. Okay? I agree with that. Okay? But there are many different ways to make sure posterior teeth do not interfere. Okay? Thank you, Mylene. Okay? Yeah. Okay? So that phonetic testing is how we're gonna, one easy way for us to evaluate their envelope of motion. That's why phonetic testing is so important. Because it's hard to evaluate their envelope of motion when they are chewing food, actively chewing food. So most people who tell you strong anterior guidance, strong canine guidance, they say if your jaw goes up and down vertically, don't have a chance to go sideways too much, then you prevent the posterior interference. That is one way to do it. Yes, that's true. But what if I made my posterior teeth in such a way that even if my jaw goes sideways more, that they don't interfere? Then I achieve that goal without having to have strong anterior guidance, canine guidance. I really hope this part, it makes an indelible mark in your ability to remember today's session, because this is the critical part, absolutely critical part so far, this book. And we're going to be coming back to it, one example after another example later on, okay? But I can't emphasize enough, okay? Teeth are the last. As such, they have to learn to line up with the bone and the muscle. When the teeth don't line up to the bone and the muscle, that's when we have problems. Teeth cannot overrule the muscles and the bone. And guess what? That's what orthodontists try to do every day. They take somebody who's a class 3 and try to make him into class 1. They try to take somebody who's a class 2 and try to make them into class 1. And I'm not wholesaling orthodontists. No, of course not. But that's oftentimes the reason why you see so many people with occlusal problems with or after orthodontic treatment, with or without Invisalign, particularly with Invisalign. Okay? So here's interesting. The dynamics of equilibrium, page 31, the last paragraph on the right side. Okay. The reason we put so much emphasis on harmony between the TMJ, the anterior guidance, and the posterior teeth is because even the slightest disharmony can cause severe hyperactivity and incoordination of musculatory muscle function. Okay? So just remember, okay, remember, and I want you to read the book one more time. There is a lot of things to remember here, okay, in this book, okay. And then if you have any questions, please feel free to write them down, send them to me in email. I can try to explain it in a different way or whatever, okay. I don't want to, keep beating the dead horse. So if you think the horse is dead enough, I'm gonna move away to chapter 5 before I get to Mari's case. I want to at least start talking about chapter 5 before we before it's a very short chapter. If you think about it, lots of pictures. Okay, and if you read the book and follow the descriptions and the writings, it's actually not a difficult thing to follow. But here's the thing that I will just emphasize here. Number one, almost every one of us, actually, I say every one of us, have seen the diagram on the cover page of chapter 5, page 33, the nicely illustrated, you know, lateral pterygoid muscles and the disc and the retrodiscal complex. To me, it is not until I read Dawson's book that I realized I was looking at the TMJ assembly. Take a look at the page 35. Take a look at the page 35. Okay. First, the entire mandible. When you look at the entire mandible picture, figure 5-2, 5-2, you realize the condyles are not like parallel to each other looking straight forward. They're slightly tilted because our mandible is slightly tilted. You know, they're almost like a little triangle, right? It's not a rectangle. It's a modified rectangle that looks like a triangle. That's number one. And as such, if you go to figure 5-4, where that condyle fits into the socket, glenoid fossa, your glenoid fossa does not look like the lateral picture like the figure 5-1, but glenoid fossa, as it goes towards the medial, it gets narrower. As it goes out laterally, the socket, the fossa becomes wider. Our condyles are meant to have, okay, in and out movements, lateral movements, and as it goes outer aspect of the fossa, our condyle has the ability of much more further movement, forward and back. And then when you look at figure 5-3, you're looking at that from frontal view, you realize again the disc has not only it resides between the glenoid fossa and the condylar head, and when you're looking at it from the side, you kind of think about it as going forward and back, but it actually has the dimension of medial lateral dimension. And that is important because sometimes your disc gets dislocated medially, just as it oftentimes gets dislocated anteriorly. And oftentimes it's medial-anterior dislocation. Okay? So when you look at all this, this is really important now. And then the last thing that I wanted to emphasize from this, okay? Okay. I'm gonna, before I share the thing that I was looking at was page 37. Page 37. I'm up to page 37 now. Okay. Left-hand column, second paragraph. As further evidence that this is a stress-bearing joint, all of the articular surfaces of the condyle, the fossa, and the eminence are covered with avascular layers of dense, fibrous connective tissue. The absence of blood vessels is a sure sign that those specific areas are designed to receive considerable pressure. The avascular areas are also devoid of innervation, and this includes the bearing areas of the disc. So if the condyle and the discs are in proper alignment in the fossa, they can receive great pressure with no sign of discomfort, since there are no sensory nerves in the bearing area to report discomfort. Okay, the disc itself is a classic example of design for function. It is composed of layers of collagen fibers oriented in different directions to resist the shearing effect that might occur in a sliding joint. the bearing area is avascular. Now, what I'm going to do is I prepared let me see. Yeah, there you go. So I'm gonna send you on a chat a little link to YouTube video from University of Michigan anatomy class, a quick anatomy thing. So you can actually open that, and then before we close out today, you can take a look at it. I was gonna play here, but I know that my bandwidth for my Wi-Fi connection in my office may not make it cut off. So I'm gonna just kind of let you watch that, okay? And the reason why I am I want you to see that is because oftentimes, oftentimes we don't appreciate all the intricate different hard tissue, soft tissue differences that we are looking at in our TMJ. It is it is far from a articulator. And oftentimes, but because of our articulator experience, okay, from dental school, we subconsciously keep comparing our TMJ to articulator, ball and socket, ball and socket. But you need to really look at, we need to really look at things from a more of an organic tissue nature. Okay, so this chapter basically talks about the presence of disc and the importance of avascular nature of the disc, the flexibility, the movement of the disc, and the musculature that stabilizes that disc and the mandible, right? And then um, it's important that you read through, and if you have any question about it, please let me know. Those of you who may not have listened to my other lectures before, I will say this. Page 41, he talks about arteriovenous shunt, what we normally refer to as retrodiscal complex or retrodiscal plexus. Okay. So the disc itself does not have a lot of blood supply, but the retrodiscal tissue does. Not only are they very painful if the disc escapes through the anterior position so that the condyle compresses on this retrodiscal plexus, but also that when you look at that, you see that there is a major artery supplying to that plexus of capillaries in that area, right? On page 41, figure 5-8B, okay? Right behind there, for most people, is our inner ear canal, okay? So if you have that plexus of blood vessels that are inflamed and in pain because of the pathology going on there, okay, it is not uncommon for those patients to complain of ringing in the ear or earache. And the ENT says there is nothing going on with the ear. Okay, it is actually their TMJ. The experienced ENTs will refer the patient back to the dentist. And the dentist, hopefully, he is hoping that the dentist knows how to control this. Any other questions? Anything that you want to specifically talk about? Okay. Please read this page carefully, okay? Because a lot of the concepts that he talks about here, we're going to come back and forth, back and forth. And when we start talking about clinical dentistry. So this chapter and the musculature chapter oftentimes kind of turn off people, but I want you to try to read them one sentence at a time. I hope that link that I sent was able to lead you to the YouTube channel. Okay. Okay, yes, thank you. Okay. Okay. Now let's